Hi friends, hope all of you have done the exams well, and we will try to recollect some questions which have been asked for us from anesthesia point and see how we can learn from that. Okay. This is going to be an interesting session because we have quite a good number of questions covering various aspects, and these are all important questions which has been repeated from our notes. So we can see those notes are really important and you can get back to it. Okay. See, in this session, most of the questions we will see has been repeated from the previous years, either from the INICT questions itself or from a neetpg point of view. Okay. Now, please see the first question itself. See, the 55-year-old man, weight 70 kg, admitted with acute pancreatitis and related complication. So, they say that the patient has got some disease, an infective pathology, is gradually deteriorating and has been intubated and is on ventilator with the following setting. So, they gives a spectrum of disease which deteriorated and patient on ventilator, probably an ARDS kind of picture. Now, they are giving a few parameters which they have used for setting on the ventilator. For example, the tidal volume as 420, respiratory rate, PEEP they have given, FiO2, and then they have taken an ABG and given the ABG findings. So, they are asking what is the next step we should use. This is a very practical, beautiful question. Now, we will see this in detail. So, anytime when you sit on ventilator, you set a ventilator for a patient, you know that there are 5 points which you always look at. Like for example, the FiO2, that is how much amount of oxygen you are going to give the patient. What is the PEEP you keep? Third, what is the pressure support you give? What is the tidal volume you give? And what is the IE ratio you give? These are essentially the areas which you need to consider when you put a patient on ventilator. We will now learn which is the normal values. See, for a normal patient, we start FiO2 of 0.4 to a maximum of 1, which is 100%. And for a PEEP, it has to be anything between 5 to 15. That is what we usually keep of centimeters of water. Now, pressure support is usually given as 5 to 10. That is the one which we normally keep for most of the patients. Tidal volume, it is initially 8 to 10. Now, we are trying to reduce it as minimum as possible. For a general patient, we will keep it as 8. Okay. Now, IE ratio is 1:2. It can go up to 1:3 and even reverse depending on what kind of disease you are doing. So, this is the basic for a normal patient on ventilator support. Now, coming back to the question, we will see what this patient has got. This is a 70 kg patient with ARDS. ARDS, there are few concepts which you should know. Say for example, in ARDS the concept is that we would like to keep the lung inflation minimum. Okay, we will try to prevent the collapse of the lung. So, lung inflation minimum means we will always try to keep the lung volume as 5 to 6 ml per kg, the tidal volume. So, this is kept from the 8, it has come down to 5 to 6 ml. So, if you consider in this patient for a 70 kg patient, considering the 70 kg is its ideal body weight, we all has to remember that the actual body weight is not considered while setting the ventilator. We actually go with the ideal body weight, isn't it? So, 70 kg, considering it is not his actual and which is needed for calculation. So, 6 into 7, probably 420 ml is a maximum what you can give, and that is what the patient is getting. Now, see the next area, the PEEP. PEEP is kept as 12 centimeters for this patient. I already told you for a normal lung we keep up to 15. What is the second concept in ARDS is that we prevent the collapse of the alveoli. Understood? We prevent the collapse of the alveoli. This is prevented by providing a positive pressure even during expiration. So, even when the lung is collapsing, we provide a positive pressure so that the lung is kept open even in expiration. This is called the open lung concept. And open lung concept is a low tidal volume is called a baby lung concept of ARDS. At the same time, an open lung concept concept, allowing the PEEP to go a bit above. You can give up to 15 to 18 centimeters of water in case of ARDS. But remember, in any of this condition, the peak pressure would not go beyond 30 or 35. That is a maximum which is safe to give. So we need to adjust accordingly. Although we having said that should not keep it very high, you have to keep the PEEP limiting the peak pressure to less than 30 or 35. 35 for one number if you are looking at. So in this case, this patient is already having a 12 PEEP, which is almost towards the higher end. If need, you can increase a bit of PEEP if needed, if there is a problem with oxygenation. But they have given an SpO2 value set telling that the oxygenation is 100% and an SaO2 anything about 88 to 93 is considered to be safe for us. Okay, so this patient practically need not have further oxygen coming into the patient's body. So that is what the concept is. Now coming to the third important aspect, FiO2. See, FiO2 they have kept it almost 90%, 0.9, which says that it is at 90%. Now the point here is this is something which is going to detrimentally affect the lung mechanics as well as the lung health of the patient. Healthy lung issue, the lungs will be damaged with such a high amount of FiO2. Okay, so the idea is maintain an SpO2 anything above 88% or PaO2 of anything above 60 to 100 is our target with the minimum FiO2. Minimum FiO2. See, PaO2 is 110. We need only something around 60 to 80 in this case. So that means the first step we have to do in this case is to reduce the FiO2 from 0.9 to as low as possible in order to maintain a basic PaO2 of 60 to 80, because presence of increased concentration of oxygen, which is considered as a drug, is going to damage more by production of free radicals, all of you are aware of. So that is probably the next step which we have to do. Now we always think, see, there is some amount of hypercarbia, why don't we treat it? See, why hypercarbia? PCO2 of 40 is considered to be normal, but in this case 48, which is hypercarbia. That brings us to a concept in ARDS called permissive hypercapnia. Permissive hypercapnia, where you can allow a bit of hypercarbia in the body. So that means even if with this much amount of PCO2, patient is stable, it is permissible. Now in fact what I am trying to say, that if the pH is above than more than 7.3, you can allow a PCO2 of this. Okay, you need to treat it with bicarbonate only when the pH falls below 7.3. Okay, so in our case it is 7.33, 7.35 to 7.45 is considered as normal. Okay, so although it has come out a bit of into the respiratory acidosis with retention of carbon dioxide, and there is a compensatory elevation of the bicarbonate, all this is considered to be normal and you can accept this. This is the whole concept. So coming back to the question, see, when the FiO2 is kept as 0.9, your PaO2 is 110, which is quite high. So try to reduce this FiO2 is probably the first step which you have to do. Okay, so this is the first step to do FiO2. Now PCO2 is 48 or hypercapnia. What you have to do is, even if you have to do that, it is not reduction in the respiratory rate. In fact, you increase the respiratory rate, which is not there in your option, is probably the next step in order to remove the carbon dioxide. Remove carbon dioxide, which is not there in your MCQ. So that is also not the answer. Now increased tidal volume we should not consider because it's already at 6 ml per kg, giving it a value of 420. Now PEEP to 14 from 12 to 14 is the next option, which is also not to be considered because PEEP increased when there is a problem with oxygenation. Here oxygenation is not affected, it is already hyperoxygenated or oxygenation is more than adequate. So that is also not your choice. This is how you interpret this question, and I know this is a very beautiful question which covers most of the aspect of ARDS. I hope those who have got the insight to ARDS would have definitely got this. Okay, so hope we will see the next question. Now this is again a repeat question which we have already discussed in our previous videos. Which of the following test is depicted in this image? This is hand which is occluded from both sides. The radial as well as the ulnar is occluded from both sides, and they have asked what kind of test is being done. As you all know, this is very commonly performed by anesthesiologists when they put the intra-arterial cannula. You know, the most common site where we put the intra-arterial cannula is the radial line or the radial artery. So if we occlude or damage the radial artery by any means, now if you damage it by any means, we should always make sure that your ulnar is patent. So for that we use this test which is known as Allen's test. In Allen's test, what we do is we clench the hand, occlude or exsanguinate the palm, then occlude both the radial as well as the ulnar, and then slowly release the hand. Okay, while releasing you can feel that it has become pale. Now you immediately release the ulnar, okay, and if the hand regain its color in 7 to 10 seconds, it is considered to be normal. That means you have released the ulnar, so ulnar is patent. So even if you occlude the radial, this hand will remain in good condition, or it will be adequately perfused because within 10 seconds it has been perfused. Now if it is taking more than 10 seconds, then it says that the ulnar collateral is not proper and we need not injure the radial which is giving the collateral supply. So that is why the importance of doing an Allen's test or a modified Allen's test in this manner becomes important. Now in such cases we have to look for other sites for cannulation like dorsalis pedis, femoral, etc. or brachial. There are various options. This is the concept of Allen's test. So the answer is quite simple, and this has been a repeat question. It's an Allen's test. Now they have also given few tests which you can learn, which is really important. Hudson test, costoclavicular compression test, Wright test and Roos test. These are 4 tests which you can learn for thoracic outlet obstruction. All of them depicts thoracic outlet obstruction. Now because when they occlude this, the face will become congested and you can see the patient's difficulty. So this is essentially done in any case when there is an SVC or a thoracic outlet obstruction. Okay, so remember these name tests: Hudson, Wright, costoclavicular compression, and the Roos test as tests for thoracic outlet obstruction. Now please do remember these tests, which can also be an important test that can be asked for you. For example, Tinel sign. Tinel sign is nothing but tapping the ulnar nerve in the ulnar canal, and you get a neuritis for the along the distribution of the ulnar nerve. This is called Tinel sign. And Fallon's test and Durkin's test. Durkin's test and Fallon's test is basically for carpal tunnel syndrome to identify. In Durkin test, you are actually, it's otherwise called the median nerve compression test. You are actually compressing the median nerve to stimulate the nerve or to get a tingling sign along its distribution. This happened with the carpal tunnel syndrome. So all these are additional points which can be used to you when it comes to other questions, especially when it comes to neurology or orthopedic question papers. Okay. Now another favorite area of examiner, which is an area, as all of you know, that will never go without being asked. This is about resuscitation and basic life support. You know, here for a change there has been continuously asking about compressions and this time they have asked about ventilation. But the question remains the same. Now they have just asked the most important point, which is known as high quality compressions. So what is it called a high quality compression? So when you call it as a high quality compression, there are 4 points or few points which you should know. One, the rate should be adequate, the depth should be adequate, the site should be clear, and then the recoiling should be there. Now rate is to be given 100 to 120 per minute, depth is 5 to 6 centimeters, site is the lower half, isn't it? Lower half of sternum, and always provide adequate recoiling time. Now how do we prevent adequate recoiling time? Is to prevent the hyperventilation. Because if we are giving hyperventilation, it will not allow the heart to recoil, the chest wall to recoil, so that there is adequate filling. This is by controlling the rate of compressions and also the rate of ventilations. So ideally, the ventilation, once an advanced airway is in place, it has to be kept 1 breath per every 6 seconds. This will amount to 10 breaths per minute. Okay, it is never 25 per minute, it is 10 breaths per minute when advanced airway is placed. When advanced airway is not there, when you have got mouth to mouth breathing or simple bag and mask, it is always 30:2, that all of you know. But this is about when somebody has put an advanced airway, how rate you will ventilate. It is 1 breath in every 6 seconds. So it will never ventilate at 20, it will only ventilate at 10 breaths per minute. When you provide reasonable or optimal ventilation, in turn you are providing better time for recoiling and better venous return. That is how you effectively improve the cardiac output. That is how it contributes to high quality compressions. Okay, so this is rate of compression 100 to 120 is correct. Depth of compression 5 to 6 centimeters okay, and allowing chest to recoil is also okay. But respiratory rate has to be kept at 10 breaths per minute. So the answer is A, C and D. This is a very common question. As you all know, most of you would have got it right, isn't it? The next question, this is about a meconium-stained baby. So when a baby is, at times anesthesiologist will be called in to the labor room to assist a baby who has been born with a history of meconium staining. So you can see 2 kinds of babies. One is a vigorous baby and a non-vigorous baby. Vigorous baby, you don't have to do anything, just do a gentle suction of the mouth and then hand it over to mother. Cover the patient dry and cover and hand it over to the mother. Okay. And if it is a non-vigorous baby, what do you mean by non-vigorous? Mean the baby is not crying in the first 60 seconds or the tone is not adequate, baby is like a flabby, then the cry is not good. In such situations, you should always think about initial resuscitation very importantly. The most important point is do a warming, then gentle suction. This is to be only onto the mouth, and then drying up or position the patient properly, position the baby in a comfortable position, and then if the patient and non-vigorous baby, as you all know, the breathing pattern is also not good in such patients. If the breathing is not good, we have to assist this patient. This is done by giving positive pressure ventilation. Okay. The most important indication is when the patient is septic or the saturation goes down, there is a central cyanosis or the heart rate comes down, especially less than 100, you should always think about, you should always be very careful in such babies. Then think about positive pressure ventilation in such situation. So primarily, if you come back to the question, intrapartum suctioning is out long time back. We don't do any intrapartum suctioning for long time. So that is out of question. Intratracheal suctioning, you may think that since it's meconium aspiration, it was gone down into the trachea, we do an intratracheal suctioning? No. Intratracheal suctioning in a non-vigorous or a vigorous baby, no question. In non-vigorous baby also, deep suctioning is totally out. It is totally out. And positive pressure ventilation on a non-vigorous baby after initial step, that is probably this one which we can think about, that is considered to be okay. And gentle suctioning of mouth in a vigorous baby. So this is probably a multiple answer question. So in that you can go with C and D, where both these options are correct. Anyway, the concept is what is important, which you should look. So look whether a baby is vigorous or non-vigorous. And non-vigorous means poor breathing pattern, poor tone, and then poor cry. So you should always worry about such babies. In that patients, bring to the warmth, position the patient properly, do a gentle suctioning, then assess for the breathing, and then look for signs of danger, like example the heart rate coming down, baby becoming blue. In those cases, do a positive pressure ventilation. Okay, so these are the ways how you manage a case in your newborn resuscitation room. Okay, now please see the next question. A patient in ICU after waking up from coma was given morphine. Although the question has become a bit of elaborate, the answer is very simple. As all of you know, by the time I read this question, you would have gone to the answer. So after morphine was administered, patient developed respiratory depression. Which of the following drug must be given to treat respiratory depression? It's a very simple question. So you have to use a agonist like morphine, which has been used, and now you have to use a antagonist for that. So in fact, opioid antagonist is the question. So pure antagonist is, we have two of them, naloxone and naltrexone. So the question is, why is it used? It is used to treat a emergency situation like a respiratory depression. So we want a drug which is a pure antagonist. Naloxone is a pure antagonist, isn't it? Pure antagonist, fast acting, because it is treating respiratory depression. So this is the option. Naloxone is the option in such case. While naltrexone is also a pure antagonist, but the problem is it is actually slow in action. Most of the time it is oral and it takes some time to act. Respiratory depression, which we need to treat immediately. The advantage is that it will persist for longer duration, 24 hours it can act. It is essentially used to while treating opioid addictions. Opioid addiction management is what it is used currently. Okay, while naloxone, the problem with naloxone is that it is short acting. Although it is fast acting, it is short acting also. So the patient can again go for respiratory depression if the patient is having a drug which has gone for a prolonged action. So in those cases, we will have to do repeat administration of naloxone, or we have to put the patient on an infusion. Usually in an adult case, it is 100 microgram, which is given as a small bolus and then repeated as and when needed. If it is child, it is 5 to 10 microgram per kg, which is usually the initial dose which is given for naloxone. Now buprenorphine. Buprenorphine is not to be used as such agonist antagonist, which is not routinely used in the management of such cases. It is used as an adjuvant in treatment with a multimodal analgesia. Bupropion is actually a newer antidepressant which has come up, which is usually used in treatment of seasonal affective disorders, which is not much of related to our topic. Probably you will learn this more in your psychiatry or pharmacology sessions. The next question is about a 15-year-old boy reported to emergency with breathing difficulty. He has got a breathing difficulty, and the monitor attached the following graph was seen in capnography. What is the diagnosis? Okay, the graph of this pattern, they are asking what is the diagnosis. You know, if you recollect, see this diagram, we have an inspiration, we have an expiration, and then is an inspiration. In the inspiration, you have phase 1 where the carbon dioxide exhaled is minimum, because this is the dead space air, and then you have a phase 2 which is actually the alveolar air coming out, and then you have a plateau phase which is again an alveolar air, and then at the end of expiration, this is the peak expiration, peak expiration, you get the EtCO2 value, and then the inspiration start. As you can see from here, once the inspiration start, the carbon dioxide level comes down to 0. Okay, this is a normal graph. Now what happens in cases of asthma or bronchospasm, as in this case, acute bronchial asthma or a bronchospasm, the plateau phase becomes sloped, which is in turn, this is a plateau phase which has sloped plateau phase. This is otherwise known as the shark fin appearance. Shark fin appearance, isn't it? So most of you would have learned this. This is a repeat question. There is no exam without a question on EtCO2. So this has been repeatedly asked. I will just share with you a few questions which has been on multiple repeats. For example, this is what is known as the curare cleft, isn't it? This is our classic shark fin appearance seen in COPD, asthma and bronchospasm. And then you have a initial EtCO2 and then which disappears as in esophageal intubation, and then you have a gradual rise as in case of hypermetabolic conditions like malignant hyperthermia, neuroleptic malignant syndrome, etc. So these are all repeat questions which has been asked. There was also one question which has been repeated, like an EtCO2 is there, suddenly there is a drop in EtCO2, which essentially means that there is a block in the tube or a disconnection. Okay, so all these questions are really important. Please go back to our notes and have a look. This is very important. This has been multiple times repeated for exams. So this is again going to come for your next exam. Now the next question is minimum platelet required for an elective surgery. It's a very beautiful question. Appears simple, but they carry a recent trend in the questions. So initially we all started with platelet count as 1 lakh to perform any procedure. Let it be surgical procedure or even let it be an anesthetic procedure. Now every year new edition is coming. The textbook says that you can come down on the platelet counts. We have seen that patients even with a platelet count of 20,000 walking around during our COVID scenarios or a dengue fevers with no much of spontaneous bleed as we expected. So that is probably one of the reason which made them reconsider. So now according to the current recommendations, 50,000 is the minimum platelet count which is needed for a neuraxial technique to perform. Neuraxial technique means central spinal anesthesia or an epidural anesthesia to be performed without causing much of a problem. Similarly, the same 50,000 is a platelet count which need to be maintained when you take up a patient for an elective surgery. But remember, this may be a bit different when it comes to certain surgeries like neurosurgery, spine surgery, where even a small amount of hematoma can be detrimental. In those cases, we may try to keep the platelet above. Okay, if you ask me the practical aspects, below 50,000, you should not use any procedures. You should not, whether it is a central neuraxial blockade, whether it is an elective surgery, below 50,000, no and no. Between 50 to 80, depending upon the scenario, depending upon the surgical emergency, depending upon what kind of patient you are dealing with, you can think about that. Above 80,000, above 1 lakh, neurosurgeries, spine surgeries are okay. So this is in general what is being practiced. Coming back to MCQs, 50,000 is the value which you should learn for performing neuraxial technique, below which it is absolutely contraindicated. 50 to 80,000 depending upon the patient scenario and the clinician's observation, you can think about it. And above 80,000 neuraxial techniques perfectly okay. So this is how a practical point of view will apply. Next question is about a center line, again a center line which was inserted in a total parental nutrition for a TPN. All the following complications may be seen except. So we will now see a few points about the center line. So once you put a center line, mostly you may put it either through the subclavian or through the internal jugular. Okay, right internal jugular is most common and subclavian is another option. Right now subclavian most of us doesn't do because it has got problems with pneumothorax being more or puncturing of the vessels, which is the subclavian artery get punctured. So those issues are there. So we don't perform subclavian cannulation very often nowadays because we are more happy and familiar with the use of ultrasound to perform a right IJV cannulation. Whatever it is, irrespective of the route, it has got its own complications. So the first thing we do is, after doing a IJV cannulation or a subclavian cannulation, we send the patient for an X-ray. If the patient is not to be transferred, we ask for a portable X-ray to find out whether there is any pneumothorax or is the tip is in of the CVP catheter is in correct position, because at times you may see that it has gone into some other vessel, it has gone above and things like that. So as you can see in this picture in this X-ray, you can see the CVP in position at the junction of SVC and RA. Now the next option is, we will see about the complications. One, I told you the immediate complication is pneumothorax and injury to the vessels. If it is on the left side, the chylothorax is another complication of IJV cannulation. Then most of the ICUs get into, if prolonged CVP cannulation develops catheter related infection, and infection is a very common complication with prolonged CVP catheters, which can even contribute to ventilator associated pneumonia. So secondary infections is another problem. Now when you start feeding the patient through CVP, the total parental nutrition, as in total parental nutrition, all the complication of total parental nutrition like the refeeding syndrome can happen. Now what is refeeding syndrome? Irrespective of the route of administration, when you give nutrition to the patient, carbohydrate to the patient or even protein to that extent, it will result in all kind of vitamin deficiencies to aggravate, electrolyte abnormality to happen, the hypophosphatemia, hypomagnesemia, etc. to happen, and then it can result in further weakness of the patient for a transient time. So refeeding syndrome can also be there in such patients. Okay, so if you come back to the question, can aspiration be there? That's a very simple question. Although the paraphernalia they made it big, the answer is very simple, logical. Now once a CVP, if you start feeding through the CVP, there is no question that it should go into the lung. To produce aspiration, there should be two things. Number one, it should enter into the lung or into the trachea. So anything other than air enter into the trachea or the lung is called aspiration. Let it be blood, let it be food particles, even saliva. So it can only be possible if you take anything through the oral cavity or oropharyngeal area and then go inside. When you feed through the CVP catheter, there is no question of getting into that area. So aspiration can never be there. While pneumothorax, refeeding syndrome and infection, as we have seen in the discussed, can always be a part of a CVP, line in situ, isn't it? So that is something which is important to us, and it's a very informative question. Which of the following is not severe COVID criteria in a patient admitted with ICU? Again, INICT and AIIMS have come up with a current relevant topic about ICU and COVID patients. Most of you as well as we all together has emerged from that dark era, which I should call, because it has been a real struggle, and we have gone through all kinds of ventilation during that aspect, during that period. So finally, coming back to your exam, if you ask me one point, this COVID is primarily affecting during, at least during the acute phase, affecting the lung, and that is the one which all the criteria are basically meant for. Then only it goes to only in a very severe condition or in a sepsis condition it affects the systemic blood pressure. So effectively, you don't have to worry about the MAP in any criteria. So that is the nutshell which I have to give. Now please see the gradings which is provided. Probably this can be of help to you in your next exams. So please try to remember this. So when in adults, you classify them into 5. So most of us during this time even roam around with test positivity with no symptoms. This is called asymptomatic patient or pre-symptomatic patients. Test may be positive, but you have no symptoms. In mild COVID, we have symptoms and signs like small amount of running nose, small mild fever. You take an X-ray, it will be normal, and then no dyspnea or shortness of breath is not there. Then it is called a mild COVID case. This is again, you can go with an OP. In a moderate case, we have clinical features along with that some X-rays suggestive of a pathology or some haziness, but you keep an SpO2 and we have all features of respiratory, small discomfort, difficult to mobilize, such kind of problems can be there. Shortness of breath may initiate, but your saturation remains 94 in room air, okay, more than 94%. This is okay. This is moderately severe condition. Now coming to severe illness, this is the one which we need to admit the patient and treat aggressively. These patients, saturation has come down, the PaO to FiO2 ratio has come down to 300, that means it is gradually going to ARDS, and respiratory rate is more than 30. It's going to be, normally we don't breathe very comfortably, up to 30 it's okay, more than 30 you start developing that shortness of breath, your accessory respiratory muscles. So this is an indication of severe ARDS or severe COVID getting into ARDS. And in those cases, if you take an X-ray, you can see there will be infiltrates. So all this suggestive of a severe condition. Now critical illness, definitely patient is on failure, in shock. This is the situation, multi-organ dysfunction. You get to develop hemodynamics affected, BP falls down and all kind of renal damage, things settle down, comes down by critical illness. So this is how you grade a COVID according to the current guidelines. So among which MAP, since it has got only one option, MAP of 70 is not to be included in classification of COVID criteria. About the infiltrate concentration, I know you will be looking at it, but we don't know whether this has been exactly recollected. Even if this is about CT, not about X-ray. So I would like to, if it is a single option, I would definitely rule out MAP as the option for this question. Now, very old question, still relevant, very important. This is about massive blood transfusion. I know massive blood transfusion has been covered by various teachers in different aspects and all of you are familiar with it. So I just want to recollect that hypokalemia will never be there, because as you all know, what you are dealing with is hyperkalemia. You are dealing with this hyperkalemia because you have increased potassium from the stored blood. Okay. So hyperkalemia is the complication, metabolic complication. Along with that, you always get hypocalcemia because the calcium chelators take away the calcium. So hypocalcemia there, hypomagnesemia can also be there. All these are complications of massive blood transfusion. Of course, 1 or 2 units won't cause hypothermia, but a massive blood transfusion can bring about the temperature also. So hypocalcemia, hypomagnesemia, hypothermia can all be there in massive transfusion, while it is hyperkalemia in case of massive blood transfusion. And as you know, talking about massive blood transfusion by definition, we should know that it is replacing the entire blood volume in 24 hours. You call it as massive blood transfusion. Along with that, if you replace 50% of the total blood volume, in 3 hours. Third, if you transfuse 10 units in 6 hours, again you call it as massive blood transfusion. So all of this amounts to total blood transfusion, of which replacing the entire blood volume in 24 hours is considered to be the most accepted terminology universally. So this is what is important. So coming back to the metabolic abnormality, it is the metabolic alkalosis. So the metabolic abnormality associated with blood transfusion is metabolic alkalosis. So alkalosis, how come it occur? Most of us think that it may be metabolic acidosis, but no, it is metabolic alkalosis. This is by the metabolism of citrate by liver into bicarbonate. Okay. So citrate, which is used as a chelating agent, get metabolized to bicarbonate by the liver, producing metabolic alkalosis in massive blood transfusion. So please remember this, and please don't get confused. Okay. So in this question we have discussed about the electrolyte abnormality, the metabolite abnormality, and the definition of massive blood transfusion. This can be asked for you in various ways. That this can be at times asked as an MCQ or as a part of some MCQ. So remember, this is really very important for you. Okay. Now please see the next question. A 28-year-old girl brought to casualty, right femur, shaft of femur. The patient has conscious oriented. Okay. Was conscious and oriented. However, after 12 hours, the time is important, he developed confusion, difficulty in breathing, rashes over axilla and chest. What is the most likely diagnosis? So it's very simple. It's fat embolism syndrome, because it satisfies the triad of fat embolism syndrome. Even the timing comes to your diagnosis. So whenever there is a higher mental function deterioration followed by hemorrhagic manifestation and dyspnea in a setting of a long bone fracture which is not treated, this is exactly a scenario. It's a beautiful situation for a fat to embolize. The fat can embolize into the blood. It reaches into the microcirculation, occlude the microcirculation, and produce all kind of problems. This is how it happens in its pathophysiology. Okay. So we will see Gerd and Wilson has classified as a respiratory depression, CNS symptoms, and petechial rash, which is classically seen in our case as a major criteria for diagnosing fat embolism syndrome. Along with that, there are some minor criteria also. You please go through that. You can see that the tachycardia, fever, jaundice, renal, etc. These are all come into the diagnosis. So any two major criteria is definite, along with one major. We have all the three major criteria given in the question, making it very simple question for you. Okay. So remember this fat embolism syndrome. Now adding more, it is respiratory depression or distress, altered mentation, and rash as the most common triad. And in a setting of a long bone fracture, which is the most common question which you can get, it can also happen during a bone marrow transplantation or an osteomyelitis, that means an infection, or even alcoholic disease, liver disease, or even liposuction, it can happen. As we already mentioned, it can go and damage the capillaries of end organs and cause problems. And how do we prevent this? Whenever there is a tendency, intramedullary nailing is one problem. During operation, you get into this problem. So before that, you fix the long bone so that it will not cause a dissemination of fat globules into the circulation. Filters and all are, although it is spoken very much, it is not to be used in our current future, probably at least in our settings. So fixation is probably the best option. Now, treatment is always supportive. The need of steroid and the use of steroid is still debatable. Some people say that is useful, some does not. So anyway, there is no definitive treatment right now other than supporting treatment. So prevention is probably the best method of treatment in fat embolism syndromes. Okay, all the best.